Hi, thank you everyone for joining us today. So I'm here to discuss proportional pressure support. It's such an easy mode. You'll see as we go through this. It's an easy mode. It's just new, and that's why we get scared to try a new mode. We always want to stick to what we know. But we're going to go through the benefits of this mode and should hopefully interest you in trying this mode. So real quick, my disclosures. I've been sponsored to lecture by Icon and Draeger. I am employed by Vero Biotech and Icon. I'm also the ARC chair of the adult acute section. So I always like to throw this in there. If you're, love to have you on that section. We do a lot of discussions like this. We actually talk about PAV. There's a lot of users of PAV out in New Orleans. There's a great therapist that talks about it a lot. So if you have more interest in it, you can jump on the ARC Connected to hear others' experience. So for those that don't know me, I've been a therapist for almost 30 years, and the majority of my time, 28 years, has been at the RM's Cali Shock Trauma Center. 28 years I've done different roles there in respiratory and research, and that's where I learned to use PPS with Dr. Hibashi, and another great mode. Love the mode. So our objectives is to review the current literature on the use of PPS. So it's important to know, why should we use it? What's the literature saying? So I hope this influences you to grab a ventilator, grab a partner, one place with a test lung as you're making vent changes to learn the mode and understand it, and then talking to your providers and get their buy-in, especially when you show the literature we're going to discuss. Review the settings for PPS. I promise it's a piece of cake. Review patients on proportional pressure support. So I do have patients that we did place over on PPS that I was trying to grab waveforms. So how many of you know what this is? It's Etch-a-Sketch. So probably many of you are probably too young to remember this, but this is what PPS reminds me of. So you're using these two knobs to create a picture on your Etch-a-Sketch. So for us to do PPS, we have basically two main controls. Is FA stands for flow assist, and VA stands for volume assist. FA for resistance, volume assist for compliance, and elastance. And we'll get into that a little bit more. Great to see someone else knows about it. Etch-a-Sketch. And that's why I kind of think of this. I think as us as RTs, or really any clinician managing a ventilator, we're creating these waveforms. We're becoming more as an artist at bedside. You're not just setting settings and walk away. You really have to assess your waveforms. And I always like to remind people to look at your patients as well. Back in the day, we didn't have waveforms on ventilators. We had to really interpret our patients. So it's great to use both together. And you're becoming more of an artist and trying to create the perfect picture. So proportional PAV, proportional assist ventilation, was actually created by Dr. Younes, and I'm not sure if I'm pronouncing it right. And this was actually first provided in 1992 on the Puritan Bennett on the A40s. I think now they're called Medtronic ventilators. So they trademarked the name proportional assist ventilation. Draeger then adopted the mode, and of course, because they trademarked it, Draeger had to come up with a new name, proportional pressure support. And that's what you'll see on Draeger's. I believe it was an option since the Draeger XLs. My experience with it was on the V500s. And it's interesting that the Respironics non-invasive ventilators, also like the V60, also had this option as a non-invasive proportional pressure ventilation, PPV. Again, I believe for most vents, it's an option you have to purchase. There's a lot of great benefits for this. Okay. Using this mode, don't use this mode just because I'm telling you. So it's really important to understand why. First, to learn the benefits, because then too, when you tell a physician or provider, hey, I want to try this mode, they're going to ask you why. Why should I try this mode? Why should I let you set the patient on this mode? So it's important to understand the literature behind this, and there's actually a lot on there behind it. So we all know that ventilator, let me close this little box here. Ventilator asynchrony occurs 24% of patients that may lead to prolonged ventilation. We all know that. Actually, who is it? It's Eric Kreiner that does a lot of talk about patient asynchronous. And if you haven't listened to his talks, they're awesome. So we know prolonged ventilation can lead up to 17 days of a patient being on a ventilator, when then that increased risks and complications and taking up an ICU bed. So PPS, and you're going to hear me, and I apologize when sometimes I may call it PPS or PAV. It's the same thing. It's just what's on each ventilator. So we know there's a lot of studies that have really shown that the benefits of PPS improve synchrony, demonstrates the decreased work of breathing when weaning patients. So there's a list of articles right there just discussing that. But what counts more is looking at the systematic reviews. So when I dig into literature, I look for quality of evidence, and I always aim for systematic reviews, because they're a great source of authors actually taking their time trying to answer a particular question, and they're reviewing all these randomized controlled trials. So they're answering their question and doing all the work for you if you have the same question, hopefully. So it's a great way for us clinicians trying to also keep up with everything, all the studies out there. So there's been a lot of studies on PPS that there has been actually several systematic reviews, authors trying to answer different questions. So this one was just recently published, comparison of an advanced closed loop ventilation modes with pressure support ventilation for weaning from mechanical ventilation in adults. So this was a systematic review and a meta-analysis. So the purpose of what the authors their goal was for this is to compare NAVA, PAV, ASV, SmartCare with standard pressure support regarding their effectiveness in weaning or ICU patients from invasive mechanical ventilation. And this was published in the Journal of Critical Care 2021. And I just love to point out, if everybody knows I'm Greek, all the authors here was actually published in Greece. And I'm finding out they're big users over in Europe. So the results from their systematic review, they have inclusive and exclusive criteria for what studies they included. So they had 20 randomized controlled trials that they included, and it showed PAV showed significant advantage over pressure support in terms of weaning rates, mechanical ventilation duration, and ICU length of stay. So that's really important. So there was really no significant difference found between ASV, SmartCare when you're looking at pressure support. So again, just for those that are interested, because I had someone recently asked me about ASV and PAV. A lot of the data, the studies are doing ASV versus pressure support. So really, the ASV versus pressure support didn't really show much benefit. PAV versus pressure support, NAVA versus pressure support. I love to see actually a study that would compare all these modes having NAVA versus PAV, because again, there's a lot of they're great modes. They're all better than pressure support, and that's what you guys are going to hear from these studies. So they concluded that the PAV increases weaning success rates, as we said, the shortened mechanical ventilation duration in ICU days. It does mention that it was noteworthy that NAVA seems to improve in-hospital and ICU survival. Again, for those who are not familiar with NAVA, NAVA requires an invasive procedure versus any of the PAV, ASV, PPS being the same. It's in non-invasive. So that's another great advantage. But I would love to see NAVA versus PAV. All right, this one was, I've shared this one with you before on my previous PPS lectures. This was published in 2018. This was also a systematic review. And the goal of these authors was to examine whether a proportion of modes improve patients' ventilator interactions and whether they have an impact on weaning success in the length of mechanical ventilation compared to pressure support. Pretty similar to the others, but they looked at a couple other things. That's why I included this as well. Their primary outcome, again, was looking at the asynchrony index, weaning failure, and the duration of mechanical ventilation. So the results showed the proportional modes, so they're combining all the modes together, proportional versus pressure support. They saw a reduction in the asynchrony index greater than 10% compared with pressure support. So that's also huge. As we said, asynchrony can lead to other things. When a patient's asynchronizing with the vent, sometimes we end up sedating them as well, again, increasing the length of stay on the ventilator. So again, talking about the oxygen index, and also, however, reducing weaning failure and duration of mechanical ventilation were found with only PAV. So let me repeat that here. So we saw the proportional modes all made a difference with the oxygen, with the asynchronous index, but when breaking it down, it was PAV was anyone that really reduced weaning failure and the duration of mechanical ventilation. And the last one, another systematic review, this is whether PAV or pressure support is superior for weaning remains, they felt it was unclear. So this is why these authors decided to do this review. And this was just published in 2020 in Critical Care. So in pretty big journals as well. So really important, great studies, great information, again, to share with, especially with your providers. As RTs, we should be the leaders in mechanical ventilation. So in a lot of the systematic reviews, meta-analysis, they end up using forest plots, and it's a great way of just looking at all the data. I always like looking at pictures. So you can see on the left-hand side, they end up including 7 studies, and I've actually talked about some of these studies before in PPS lectures with you all. So again, it was PAV versus pressure support and looking at the weaning success. So on the right-hand side, the weaning success, looking at PAV. So the larger size of the boxes, just also so for you to know, it means there's more weight given to that particular study, looking at the size of the patients they included. So you can see all of them show benefits of using PAV versus pressure support. And then at the end here, the diamond below shows the studies represent the overall effect. So again, showing the advantages of PAV versus pressure support. And these are studies that I've talked about in the past that were just included in this systematic review, showing the benefits of PAV versus pressure support, the probability of remaining on spontaneous breathing. So this was a study that randomized patients into PAV or pressure support after they were at least 36 hours on a ventilator in a control mode. And they kept these patients up to 48 hours, either PAV or PPS. They were switched over back to a control mode only if they met certain respiratory failure criteria. And then they did see a significant decrease in patients failing their spontaneous mode in PAV. And you can see the probability of staying on a spontaneous mode was a solid line here is when you're using PAV versus pressure support. So I thought I mentioned in there, and this one as well was in there. This was published back in 2013, randomizing again patients in the ICU into PAV, into pressure support, and they did see a decrease in vent days, ICU days, 7.1 versus 10.5, creating a significant p-value. So right there, the data showing the benefits of using this mode. So why don't we use it? We know that all these proportional modes are better than pressure support. But I also want to point out something also important. That pressure support can also cause diaphragm dysfunction and atrophy. There's been a lot of discussion about that recently. So this is a study that was that really sparked a lot of interest back on critical care medicine in 2012, when they looked at, this was an animal study looking at the fibers of the diaphragm when they were being ventilated either in various pressure support levels. Here we have pressure support of 12 and pressure support of 18 versus control mode of ventilation. And what they did see that even the pressure support can cause diaphragm dysfunction and atrophy. And don't think, oh, because your patient's in a spontaneous mode, you're preventing atrophy. Because think about it, pressure support, the patient triggers and you're pushing in pressure. So especially if if it's a lot of pressure, they're maybe just triggering and you're taking over, the vent's taking over. Is their diaphragm really contracting through the full breath? So spontaneous breathing, let's talk about unassisted breathing versus assisted breathing. So pressure support versus PPS. So the first one, and it's hard to see, is PMUS. So it's the effort the patient is making. So in pressure support, if you see the first 2 breaths, the patient's making the same effort. But on the 3rd breath, they're taking a bigger effort. Because we're on a fixed pressure, they're not going to get anything more for it. They're getting the set pressure for every breath. Do you take every breath the same? A patient that's on the vent or not? No, they don't. In PPS, as the patient has more effort, PPS will provide the more flow for that patient. So amplifies the patient's effort. So we know pressure support, was created to overcome the resistance of breathing through these artificial airways. Again, it can overcompensate and undercompensate depending on the size of the airway and the flow that's going through that tube. So unassisted spontaneous breathing. So unassisted, what happens during unassisted breathing? During the spontaneous breath, and look at the blue line represents our diaphragm. The diaphragm contracts and pulls down, pushing away the abdominal contents. This then pulls gas into the dependent lung regions and increases thoracic volume. So it's so important, because that's why it's hard, it's important to get air into the dependent lung regions. What happens during controlled mechanical ventilation? Without spontaneously breathing, the diaphragm loses tone and the abdominal contents pushes against the diaphragm. And that's how we end up getting compressing the posterior regions and get atelectasis. Okay, so what is the waveform when a patient is spontaneously breathing? We usually see it's a sinusoidal waveform, right? Patients on a ventilator, on CPAP, it's a true spontaneous breath as the diaphragm contracts, flow contracts, the patient's getting the same amount of proportional flow, where you're seeing a good diaphragm function in the picture here. What happens in pressure support? Let's think about this. Patient triggers, we're pushing in a set pressure. It's a square pressure over time waveform, and it's always a decelerating flow pattern. It has been shown, as we say, we cause diaphragm atrophy. Your patients can still get atelectasis with pressure support, right? Because again, sometimes some of the patients are weaned to extubate out of the OR, may not make a difference, but especially those patients are on the ventilator for several days, and we just had them on, let's say, a full control mode, sedated, paralyzed. Now we're switching them over to pressure support. They probably have already developed some diaphragm atrophy. We're cranking up the pressure support to get good volumes that we want to see. They contract, but we're pushing all this pressure. Are we really seeing good diaphragm contraction? Okay, so as we said, in CPAP, a true spontaneous breath is a nice sinusoidal waveform. So here's pressure over time, flow over time. We want to see that sinusoidal waveform. Guess what? That's the same waveform we can create with PPS. So I feel with PPS, we're the closest in creating a true spontaneous breath, almost looking like an unassisted breath. And we'll see the benefits. We have some data on that as well. So here's a patient on CPAP of 15 using ATC on the Drager ventilator to overcome the resistance of the artificial airway. And this patient looks great. I want to point out a couple of things that we're going to be looking at as we're looking at our patients. So, we see that we're looking at our waveform. We're looking at our volumes look great. We're going to look at RISB. We shouldn't just look at RISB just when it's time to wean and extubate someone, for an SBT trial. A rapid shallow breathing index gives you a lot of information at bedside. it lets you know, the work of breathing of your patient. Let's say I'm weaning a patient and their RISB is 120. Do you think they're going to tolerate me weaning them some more? Probably not. But looking at this patient, a RISB of 36, I'm weaning the patient and they're looking great. The RISB, they're tolerating low work of breathing, looking at the RISB. And this reminds me of a story. A patient on pressure support during rounds, the fellow said, I want to extubate this patient today. The ABG looked great. The patient was on pressure support 10, PEEP of 5, and the monitor looked great. But she failed to look at the patient. And, the patient work of breathing was really high. And I can't remember what the RISB was, but all because the gas looked good, the monitor looked good, no one looked at the patient to look at the RISB, what is actually happening to the patient. At that patient, we also looked at the P01, which was -15. If you looked at the chest, they were sucking back. So don't forget to look at your patients. And we're going to talk about P01. It's another parameter we're going to look at using PPS. So the tools were given during PPS to create that same waveform as a patient being on CPAP with ATC is flow assist and volume assist. And we're going to get into a little bit more. So flow assist is being the beginning of the breath, looking at resistance. Volume assist is more for the elastance in the compliance of the patient. So I'm going to mention EIT because we actually did a study in shock trauma using electrical impedance tomography using the Palma Vista by Draeger. And so this is a belt you can see on the patient that has 16 electrodes. These electrodes send tiny electrical currents through the belt and it's around the patient's chest, collecting data. This data then turns into these awesome images right at bedside. So these provides images of regional ventilation distribution in the lungs right at bedside. For our IRB purposes, we were looking at just observational studies, looking at patients in spontaneous modes. And we were lucky to get some patients during transitions. So this is an abstract we published a few years back in the Respiratory Care Journal. I'm hoping to work on something a little bit more, reviewing our data and turning it into an article. So basically, looking at EIT, and I love pictures. Pictures always, easy to interpret. So blue is where all ventilation is occurring. You can see the white area is probably we're over-ventilating this area. Here in the center is where we're seeing the heart. And right below the heart is a gray area. We're not really ventilating in there. We're not having gas distribution in that area. So this patient was on pressure support of 10, PEEP of 5. It breaks it down for us where ventilation is occurring, ventral, mid-dorsal, and dorsal being in our bases. And then we switch this patient over to CPAP. So we're going from a decelerating flow pattern to CPAP with ATC, mimicking a true spontaneous breath, the sinusoidal waveform. Within minutes, we see an improvement in ventilation in the mid-dorsal and dorsal. It actually increased to 13%. And I say minutes because these patients don't want to sit still for so many, for a long time while you have this belt there and collecting data. Here's another patient, pressure support of 10, PEEP of 10. Not as a huge difference as the previous patient, but we still saw an improvement in the bases by 7%. So again, they're both spontaneous modes, but really this is showing us maybe the patient's using more of their diaphragm because we're not pushing air into these patients. And as they're using their diaphragm, they're actually mimicking a more true spontaneous breath, unassisted breath, and getting more gas into the mid-dorsal and dorsal regions. All right, then we had patients that didn't tolerate switching over to CPAP. They were too weak to go yet to CPAP. So that's when the patients would go on to proportional pressure support. So the first one here is pressure support of 16, PEEP of 8. And I'm going over to PPS and a PEEP of 8. And again, you can see there are some gray area in the lower regions in the mid-dorsal going into the dorsal region. When they switched over, I see a lot more blue. Purple, we believe, could be some fluid. So again, within minutes, improvement of 4%. It would be interesting if we came back to see what happened to this patient later, or looking at the X-rays a day later. So the next patient, actually, I do know that the next day, the x-ray did improve because I was just really amazed what we saw right at bedside with this patient. This patient had a lot more ventilation on the one side versus the other. You can see a lot more gray in the dorsal regions. Looking at her settings, pressure report of 12, and I have her ventilator pictures as well. Pressure report of 12, PEEP of 8. You actually even see a negative number being displayed for her mid-dorsal, -2 and only 9% in her dorsal. When we switched her over, just look at the picture. You're seeing so much more blue, so more and more gas distribution. And within minutes, we saw an improvement by 13%. So all the data showing how it decreases improvement in weaning these patients, synchronizing these patients, but I think there's even more there to PPS that we're not realizing because we're mimicking spontaneously breathing, that we're improving just by looking at these, improving gas exchange in the dorsal regions. They're using their diaphragm more. So here's that last patient. So I didn't have a flash drive, so I ended up taking pictures with my phone. So this patient was on a pressure support of 10, a PEEP of 12, 30%, and you can see a constant pressure, decelerating flow pattern. Untitled wasn't on. I wish it was on. Untitled was great information looking at volumetrics of the Draeger. Tidal volumes were 380s, and I can tell you this was a larger patient. Resistance within normal for having an artificial airway, compliance not being that bad, 38.2. So these are all numbers you want to look at before transitioning your patient. You want to get to know your patient before you transition. You should know your patient. And then the RISB's 56 within the middle. She's not working hard. Someone said about peeping increase 8 to 12. Let me see which one is that. Yep, that is the last patient was increased. The rest remained the same. But I want to show you, she was a larger patient. Looking at her x-ray, she needed more PEEP. And you're right, it would have been interesting to see if we kept the PEEP the same. But let's look at her mean airway pressure was 15. We increased the PEEP and we still maintained this. We had the same mean airway pressure. We didn't use a lot of really high settings on PPS. We're aiming for the same amount of pressure. To see what she would develop on the EIT, on the electrical impedance tomography. So starting on PPS, and we're going to go through this in more detail, starting point is we could recommend saying 8 and 8. 8 for flow assist for the beginning of the resistance of the artificial, we're using ATC for the artificial airway, but for the natural airways resistance. And that could be, if a patient is asthmatic, they're most likely may need more flow assist. So knowing your patient, a patient with low resistance probably won't need much flow assist. Volume assist is based now looking at the patient's compliance and elastance. So we started 8 with this patient. So our goal, as we said, we want to see that sinusoidal waveform. We don't want it to look like pressure. Those actually these look pretty good. You can see in this one, she's taking a bigger effort. So if this continued, maybe we're giving her a little bit more of a flow assist. So you want to make it a nice sinusoidal waveform. So she looked good there in her RISB, and the data that we saw on the EIT was based on these settings here. But again, within minutes to see improvements, I think it is pretty amazing. So this patient, I wish I had the x-ray, but she definitely had an improvement the next day as we saw improvement on the EIT of where ventilation was occurring. And then you can see here on the pressure support, her dorsal region, the percentage of gas distribution was 5, and this shot here went to 17. All right, so you've told me enough about it. So just like my kids would say, just tell me how to use it. And I'm going to tell you, you'll be surprised how easy it is to use. So PPS is a form of synchronized ventilator support in which the ventilator is going to generate pressure in proportional to the instantaneous patient's effort. So the ventilator is basically amplifying the inspiratory efforts of the patient. So just thinking of how an amplifier works. So PPS is actually assisting to deliver the proportional to the patient's instantaneous flow and volume, and by compensating the patient's resistance and elastic load, and then amplifying the patient's own effort it's breath by breath. So again, PAV it's providing more dynamic inspiratory pressure assistance versus static inspiratory pressure. So common questions: how much flow assist, how much volume assist should I use? Again, as we talked about the previous patient, know your patient. What's your patient's X-ray? Because we need to make sure PEEP is set appropriately. And that's really in any modes. Know your patient's X-ray, their ABG. Do they have a flat diaphragm? Then I'll think about, maybe I need to back off on my PEEP. Know my patient's resistance. Do the tube size. Do they have anything wrong with their airways? Is this an asthmatic patient? Is this a patient that had a lot of trauma, airway trauma, and we can only get a size 5 ET tube in them? They're going to have a lot of resistance. Know the patient's elastance, compliance before switching over. That will help guide you in these settings. So the settings are ATC, automatic tube compensation. There's flow assist, volume assist, PEEP, and FiO2. I'm not going to get into you guys all know how to set FiO2. We discussed PEEP, looking at the X-ray, if a patient has flat diaphragm, backing off. If I'm transitioning, let's say from APRV, I'm on 20/0, P high of 20/0, and this is something common we would do over at Track Trauma. Dr. Abashi transitions a lot of his patients over from APRV to PPS if they're not ready for CPAP and ATC. So looking at the patient, if the X-ray is looking good, I want to kind of maintain the same mean airway pressure on 20/0. The mean's usually 2 to 3 below your P high. So let's say 18. So I will then aim for the same mean airway pressure when I transition over, maybe use a PEEP of 18. Transitioning a patient over from pressure support, again, looking at the X-ray, that patient was really de-recruited. We end up going up on her pressure, her PEEP to help with recruitment as well as we transition the patient over. So I believe it was a Monday morning rounds, and Dr. Bashi looked at X-ray and had the patient transition to PPS and increased PEEP. So ATC, we're going to talk more. You're using that just to overcome the artificial airway. Flow assist to overcome the patient's resistance, and volume assist for elastance. All right, so as you're setting it, you can make it look like pressure support, but you don't want to make it look like pressure support because you're not going to get the benefits of PAV. So you want to make it look like, as we've been talking about, the sinusoidal waveform. So it's really hard for me to say, do this, this, and this, and you'll get this all the time. Start at 8 and 8. Know your patient, knowing, what, the compliance wasn't that great. I might probably, I'm expecting to go up on my volume assist. And then flow assist, most of the time, at least in trauma, we haven't had to use a lot of flow assist with our type of patients. I can see if we were using this maybe in the NICU with a lot of our COPDers, asthmatic patients, those patients will probably require more of a flow assist. All right, like I said, it's hard to get into cookbook settings with this mode because we need to act more as we become an artist. You got to spend the time at bedside to find the right settings, come back maybe a half hour later and reassess the patient as they get comfortable into the mode, and then fine tune it as well. So flow assist, it's going to be based on centimeters of water pressure per liters per second, and volume assist is centimeters of water per liter for elastance. So this is for resistance. PEEP and FiO2. There's really easy. Just two controls. You really have to do it. It's that simple. And here it is. We basically become artists to create that perfect picture, and that's how I see us as well at bedside, as artists and trying to create that perfect picture at bedside. So something that we should know to understand how to understand ventilation with our patient and the ventilator is the equation of motion. If you want, good to make sure refresh your memory with the equation of motion. P standing for the pressure, the sum of pressures, either generated by our patient or the ventilator, and together, then equals the tidal volume, again, generated either by our ventilator or by the patient's inspiratory efforts, then compliance of the respiratory system, plus flow times resistance. So looking at this picture, think of it this way. The patient's PMUS, the effort they're putting in to create the breath they want, and at the same time our vent has to push. So how much pressure should the vent provide to help for that patient for each breath? So we're going to break down how our settings and thinking about our respiratory system. So as I said, ATC for the artificial airway. If it's a trach or ET tube, if you're using a non-invasive, you're not going to do there's no ATC option. Flow assist for the native airway resistance, and then compliance. For compliance and elastance, you're actually setting volume assist. So you're breaking it down to trying to give the patient the right amount of pressure they need for each versus just pressure support for all three. So we're really breaking down how much pressure we're giving the patient in each part of the breath cycle. So ATC, recommend always using it at 100% compensation. The other options is the tube size, the type, ET tube or trach, and then adding in the correct size of your ET tube. When using PPS, Dr. Habashi has found that it actually overcompensates if you leave ATC compensation at 100%. So his practice and the way I've been teaching it is using it 50%. I know a few in Europe choose not to use ATC and just use flow assist completely for the resistance. As talking with Dr. Habashi about ATC, he feels it just gets the flow in faster to help overcome the resistance of the airway. Still likes to use it, but at 50%. The key is to remember when you switch the patient off PPS, that you do compensate back to 100% if you're going to use ATC. So the flow adjustment, your flow assist is all about, this is looking at flow over time. It's the beginning of the breath, creating that nice ramp right at the beginning. Volume assist is looking at pressure over time, you're going to see the maximum pressure right at the end of inspiration. So you want to see that. Kind of reminds me of a dolphin's fin. All right, so again, flow assist in the beginning, volume assist then kicks in right after the flow assist, taking over more for the elastance and compliance for the patient to help give them the right amount of push they need to see. We're looking at tidal volume, and when we're looking at the waveform, I have examples. You don't want to see an icicle. You're using the volume assist to extend that breath, making it wider. All right, flow assist. As I said, really simple, start at 8, and then look at the beginning of the breath. Looking at the waveform. Is it ramping up nicely? Looks great. If it's shooting straight up, and I'll show you pictures, you're overcompensating. And look at your patient. Do they look like they're still sucking back, wanting more air? Give them more flow. You can actually give them the flow they need with flow assist to make sure they're comfortable. Or are you just blasting them with too much flow? Then you need to make sure they're bouncing off the bed. Back off on your flow assist. And then the compensating for the resistance with flow assist, it actually ranges. You can actually go down to 0, and we've seen some patients not really needing much flow assist. They just need the ATC, but they're needing the volume assist because of their compliance. So it ranges anywhere from 0.5 all the way to 30. I've really not seen high flow assist with patients. Again, the only time you'll see needing it higher is on those patients that have actually airway disease. All right, here's an example. What do you guys think this looks like? This is flow over time. It's shooting straight up. I'm giving too much flow assist, so I need to back off. It's hard to see this one. I use my phone again to capture this picture, but this is the waveform I wanted you to see. See, again, this is looking flow over time. The first breath looked great, but look at this one. This patient's sucking back. So you see that? I'm not seeing that nice ramp up. It's the patient's really sucking back. You see they're not getting enough flow. And if I would see this consistent, I would need to increase the flow assist for this patient because they're probably air hungry. And I actually found this in one of the Drager documents talking about setting flow assist and volume assist. It actually says about asking your patient, and I've seen Dr. Bashi talk to the patients that are awake and alert. How do they feel? They're getting enough air, and if they say yes, yeah, then your flow assist is good. If they feel like, oh, I need more air, you could increase your flow assist. In this document here, that could recommend adjusting your flow assist by 0.5. As you get comfortable, I mean, you could do it. You could do it by 1.5. It's kind of small, I feel, but increasing and decreasing it by 1. If you see a patient is really air hungry, you could increase it. I know by going up by 1 is not going to make a difference. I might need to go up by 2 or 3. And I'll also point out that after every correction, it is necessary to adjust the alarm limits. The apnea of ventilation is adapted to the patient. So the alarms in PPS are just as important as the settings, and we'll get into that. All right, volume assist. Volume assist it helps compensate for the elastic resistance caused by reduced elasticity of the lungs. The range is 0.1 to 100. So I have not seen a patient that needed flow assist and not needed any volume assist. It's usually we need more volume. I've not personally used really high volumes, but you tend to go up higher on the volume assist. I know Dr. Abashi's used really high volume assist on some patients with really poor compliance. I believe some of them were actually on ECMO. Okay, so there we go. So this is a beautiful waveform, right? You think, wow, this patient looks great. Nice sinusoidal waveform. I'm seeing the dolphin fin there. So sometimes people think, well, these waveforms look great. I bet they're not on high settings. Oops. And actually, the blue box didn't come off. I'm actually going to pop out. I wanted you guys to see these settings. Hold on. Flow assist of 9.5, volume assist of 24.9. It could be 25. So, and this is a patient that needed have poor compliance. Maybe they should have gone up on the PEEP, a 5 of PEEP. But you can see we're getting the great waveforms we need. But just an example, that there are times you will end up needing high volume assist. And I think I have another picture of this patient where you can see all the other parameters as well. So a couple of things in volume assist. If your goal is to see the nice dolphin fin, if you start seeing it squaring up on the top here, or even the flow at the top squares off, you more likely have too much flow volume assist. So let's look at this patient. I love to see what you guys think about this one. If you want to throw in some comments in the chat box, this is the pressure over time. Let's look at it together. We're seeing it really kind of squaring off on the top. It doesn't look like a fin. Let's say that. The flow, it's not sinusoidal. It's shooting straight up. My tidal volumes are small. I wish I had Risby up on this one. Respiratory rate of 19. What's your thoughts on this? Flow assist of 8, volume assist of 14.6, 5 of PEEP. Anyone will make any recommendations here? Thank you. Flow assist is too high. Correct. It's shooting straight up. Let's back off on the flow. This patient doesn't need the flow, but what do they need instead? They need volume assist. We need to widen that up. It's too narrow. All right, let's look at this patient here. So PPS, we're on 15 of PEEP. Here's actually one of the few that you'll see high flow assist. And I wish I remembered the scenario with this patient. 20 of flow, volume assist of 10.7. The respiratory rate was 13. Let's look at, you're coming in and you're seeing this. What would you do in this case? My tidal volume is 854. My RISB's on the low end. So remember, RISB on the high end, the patient's working hard. RISB on the low end, they're not really working, not really working hard. The vent's doing more for them. But we would like to see the RISB more in the middle. What are your recommendations if you walked into a patient and looked like this? All right, Amanda says, okay, flow assist. What about the flow assist? So we do see there is a little ramp. Maybe some of them are shooting up. So yeah, maybe I can back off on that. What are we seeing up here? Do you see how it's more squaring off? It's kind of also, it kind of starts flattening up on the top. Maybe we could actually, back off on the volume of this patient. Look at these volumes are too big. So we want to back off so the patient actually could do some of the breathing. One therapist made a note of this to me. That's why I threw this, the data on the right-hand side. Let's see if it's popping up. There it is. The inspiratory time. We know what we like to see up in a mandatory breath, like 1 second, but do you want to see a patient's spontaneous eye time being 1.47? So again, this is it's too wide, you could think of it, and it's creating that larger volume. So in this scenario, not that I focus on this really much, but it's just a great example to show you, which one do I back off? Look how long their eye time is. I'm going to back up on the volume assist on this to bring down the volume, and I'll get my RISB up. The patient doesn't need all that support. All right, good. And you guys are catching on. I mean, this is really simple. It's doing one or the other, and you're going to sit at bedside and watch the patient. And if you go the wrong way, your patient's going to let you know. All right, let's look at this one. This one has pips of 21, mean of 13. The rate's 33. My volumes are 370. My RISB's 87. And looking at our waveform, some look a little more narrow than others. I'm only on a flow assist of 2, a volume assist of 7.6. My PEEP is 10. Any suggestions? What would you do here? More flow. Yep, so I would give this more, you try more flow, because some are shooting a little bit higher than others. They're not always ramping. So some of these look a little too much flow, again, not everybody's going to need all that flow. So this one's like ramping up, but maybe stent this up open a little bit more. Maybe they need more volume assist. And it looks like this patient probably needs to be suctioned out a little bit as well. So that could make a difference. You can see the resistance is only 5.4 on this patient. Increased volume support, exactly. That's what I would try. All right, so this one, I actually gave you guys the answer on this one. Too much volume assist, again, and actually too much flow. Look how it's shooting straight up. Look how it's squaring off on the top. This looks like a pressure support breath. And this is not what we want to do. So you want to create a sinusoidal waveform, and you want to create that dolphin fin. So you need to readjust your settings to wean the patient because you're overcompensating. Again, I would throw RISB on your screen to really, again, use it as a parameter too. When you first put the patient on, maybe their RISB was 70. You come back, they've adjusted, they're liking it, they're, are they using more of their diaphragm? Their volumes are getting larger. Their RISB is down to 30. So maybe you need to, consider, and if it keeps dropping, weaning the settings. All right. Again, here's another patient. And I just want you to, again, just to get used to looking at the parameters. I'm on flow assist of 9, volume assist of 12.5. Look, I'm on a PEEP of 22. Great waveform. My RISB is 26. I'm not 26. I'm getting good volumes. Anything here you guys would want to do? So I'm a little on the lower end of RISB. Resistance compliance is looking good. I want to look at the, knowing their X-ray too. Could I possibly what? Less volume assist, look at X-ray, ABGs could come off, wean down the PEEP as well, but yes, volume, less volume. Because the flow, it looks like it's ramping, it's not shooting straight up, and they're not sucking it down, so that kind of looks appropriate. All right, so this one, so something we worry about if we overcompensate patients, and I recommend coming back and checking, because once the patient gets comfortable, and this says a rate of 18, but it looks like it's a lot less than that. This is, I think, a 15-second screenshot, and you only see maybe two breaths in here. So as the patient gets comfortable and liking your settings, you could be overcompensating where they can actually go apneic. So that's why we're going to talk about the alarm parameters are so important, because once you overcompensate, these patients end up taking maybe a couple breaths in nice big volumes, and they can go apneic. So you can see the RISB's 15, volumes 920 or 750s are VTE, and looking at our compliance and our resistance. All right, so here's that other patient that I was talking about, that I showed you the waveforms. Great waveforms, just an example when you're using high volume assist, and look at the volumes on this patient. Great waveform. So this is when you're getting the dolphin fin, but with that volume, I would most likely go ahead and wean this patient. We have a rate of 13, yeah. All right, weaning. So our goal is to get these patients to usually around 5 and 5, doesn't have to be exact, 6 and 5. I might not be using any flow assist, and I may be on some volume assist of 5. And where do I go from here? Where would you want to go from here? Here's a patient you basically having sinusoidal waveforms. They've done great on PPS. They really don't need PPS. Where am I going to go? Am I going to go to pressure support? And we want to stay on the same course and just go to CPAP with ATC. Switch the mode to CPAP, use ATC at 100%, and continue weaning the PEEP to where you're comfortable to doing a spontaneous breathing trial. So your goal is to get these down to around, anywhere 4 to 6, doesn't have to be an exact number, and try the patient just on CPAP. Not why go to pressure support, you're going backwards. Again, you're just going to be pushing in pressure. Want to go ahead and use CPAP with ATC. And I'll come back to these questions. I'm going to go through these slides. Non-invasive. You could use PPS non-invasively, as the Respironics non-invasive V60 has it. It's a great mode, again, to use it for patients non-invasive, and there is some data out there. You're going to set it the same, trying to aim for the same waveform using flow assist and volume assist. Now you don't have any ATC. You don't have ATC. So transitioning. And here's one patient I want to run through transitioning to PPS. They're on VCAC and autoflow. We were on a rate of 18, tidal volume of 500, PEEP of 8, 40%. We then looked at her P0.1. You could see normal is -4, -6. This patient was working. So, it's nice when we used to tell a provider the patient is working. They won't believe us. Here's now you have a number to actually talk to your provider about, hey, their P01 is -12.1. So this patient was working even though they were in VCAC with autoflow. So this patient was converted over to, we're getting ready to convert her to PPS. Let's see, what was her PEEP before? We said her PEEP 222 was 8. We did go up on PEEP. We then started with a flow assist and volume assist of 8, converted her over. We saw her volumes were small. We saw her RISB was high. You could see it probably could use a little bit more flow, but you could see it's the waveform isn't wide enough. So as tall as it is, it should be wide as well. So we started going up on the volume assist. We kept going up on the volume assist and started looking a little bit better. So our rate went down to 25, volumes were coming up, RISB was going down. So we left her at 15, come back and reassess the patient again. Do I need to fine tune the settings? Do I need maybe more volume assist? So it's that simple. It's flow assist and volume assist. And just interpreting these waveforms, it's that easy to use it. Flow assist, your goal is to see a nice ramp. If it's flat, give them more flow. If it shoots straight up, you're overcompensating. Same thing with the volume assist. You want to see a nice the rest remaining sinusoidal waveform, the pressure over time looking like a dolphin fin. If you're not giving enough, it's going to look like an icicle breath. If you're giving too much, it's going to look really wide, big volumes, and the patients end up going apneic. And here's getting into the alarms. Here's a patient that actually we were overcompensating in a rate of 5. She was starting to go apneic. My RISB was down to 9. So you can see it's shooting straight up my flow, I'm giving too much flow. And then looking at my volume, again, it's not a sinusoidal waveform. It looks more like almost a pressure per breath. So, and then flat on the top, I could back off on the volume assist. So again, this right here, all guiding you, hey, my PPS settings aren't appropriate. So alarms just as important. Some say set them right from the beginning, before transitioning. Set your high and low tidal volume alarms, set your high respiratory rate, make sure your apnea and ventilation is on, and look at your settings you would like to have them, and upper pressure limit as well. And I wish there was actually a RISB alarm, because I think it'd be great if the RISB was too low, then I could wean the patient. If my RISB is too high and I need to increase my settings. So be sure every time you're looking at your patient for PPS, you're also looking at the settings and the alarms. And the one thing that the fear with proportional ventilation is the runaway. So as I mentioned earlier, if we overcompensate, these patients could go apneic, but something else that can occur is called runaway. If a patient is at TLC, and any effort they make, they may be triggering, just triggering almost like autocycling, because if they're at TLC, they're not going to be able to get any more volume in. So you end up getting this runaway, just autocycling. So again, that's why the alarms are important, to pick that up to prevent that. So using PPS, you can't just set it and walk away. You really need to monitor your patient. You're the artist. Keep adjusting your picture to make it perfect. The parameters we also looked at is the P0.1, which I love, negative airway pressure that is generated during the first 100 milliseconds when of occluded inspiration. I think all vents had that. The Draeger actually offers you could actually trend it and automatically does it. You can set anywhere really from 5 seconds up to like every hour for it to actually measure it. And use your RISB. RISB is a great parameter to use it during any spontaneously modes, to look at the work of breathing of your patient. If you put a patient back on from trach collar, for example, to on the vent to rest, and their RISB is 200, are they really resting? No, so they're not going to tolerate trach collar. So again, use RISB for all, when it's available as a great parameter. There's P01. You could turn it on, so then you could set the interval how often you would like for it to assess the P01 by itself, or you could actually do one manually whenever you're at bedside. So can we teach old dogs new tricks? I think the data is there to support that using proportional modes are superior than pressure support. We're just so used to using pressure support, probably one of the most common modes, but it's old. We need to move on and try these and use proportional modes. It can really make a difference with these, especially our harder to wean patients, and showing you could wean patients faster. The patients are more comfortable with the ventilator. I did create a guidelines if anybody's interested. Just kind of what we talked about and how to set up PPS, the flow assist, volume assist, ATC, talking about PEEP, apnea, ventilation, and alarms. Looking at our parameters, RISB, P01, and weaning from PPS and going to CPAP with ATC, and making sure you set your compensation back to 100%. So in summary, in conventional ventilation, we tend to look at the delivered volume and see how much pressure the volume is required. In proportional ventilation, we assign how much pressure per unit of flow and volume that we're actually creating. It's not a new mode. It's been around since 1992. It just takes us always a while to pick up these modes or new therapies for some reason. And the data's coming out. It's out there in all these systematic reviews how beneficial it is. And I hope we get to do a little bit more EIT and trauma looking at PPS. If you want to read more about it, Draeger actually has a nice handbook actually on ATC and PPS. Thank you all for taking the time to listen today. Love to hear any feedback. If you need any help, we're always willing to help. We have customers that do send us pictures of waveforms so we can help them when they first learn using PPS, how to interpret the waveforms and knowing what to do or if they're on the right track. But you can see it's really simple. It's flow assist and volume assist and creating that perfect picture.